now have Dr. Suneeta Dubey, who's the head of Shroff Charity Eye Institute, but a prolific glaucoma surgeon, and she's heading the glaucoma department there, and we all have seen her wonderful surgery, but she has a difficult task within 7 minutes to tell us about the complication of tubes.
Thank you, Dr. Harsh. So I'll be talking about tube complications. Since we are doing tube surgeries in very complex cases, we can have complications, and there are some unique sets of complications which are associated with tube implants. They can be related to valve, or they can be related to the design of the tube itself, the tube erosions, tube occlusion, blockage of the tube, or even plate extrusion. So these are complications which are very specific to the implants. So in the early phase, we can get proximal end of the tube blocked by blood, fibrin, iris tissue lens material, or vitreous. So blood, fibrin, and inflammatory material can retract with conservative treatment, stepping up of steroids and cycloplegics. Even iris strands and small vitreous strands can be managed with anti-YAG laser. However, in some cases, surgical intervention may be required. So as you can see beautifully, we see a lot of neovascular glaucoma cases, and we manage them with tube implants. So if you just give low energy shots at the tip of the tube, then the clot gets retracted. However, sometimes you need to do the AC wash and even inject anti-VEGF in these neovascular glaucoma patients to prevent recurrence of bleeding. Vitreous occlusion anyway, even if there's no obvious vitreous and if there's zonular weakness, the tube can suck the vitreous, and sometimes it is difficult to manage conservatively and you have to do surgery. Tube erosion is a very serious complication and can happen up to 2 to 7% of the patient depending on the health of conjunctiva. If the patient has undergone multiple surgeries before, the chances of tube erosion and exposure are much more, and it can lead to ocular inflammation, hypotony, and poor vision, and it's also a major risk factor for development of endophthalmitis. Therefore, it has to be taken up very, very seriously. So if the conjunctiva is not healthy, the wound dehiscence can occur immediately post-operatively, and you can manage it conservatively also with doxycycline, steroids, and lubricants. However, if the tube erosion has happened, which happens slightly later, you have to take it in operation theater. So it's very important to prevent tube erosion, and as Dr. Putran has shown, insertion of tube through a long needle-generated scleral tunnel helps a lot, and we have also started doing that, and it prevents tube erosion and entry of the tube at 12 o'clock and not straight into the anterior chamber. In addition, suturing the tube on the sclera makes it flatter on the sclera and prevent erosion. Also, it is better to cover the tube with a patch graft. You can use anything, scleral patch graft, corneal patch graft, etc. And also, thorough cleaning of donor scleral graft to abrade all uveal tissue is essential, because immunological reaction and inflammation can lead to tube erosion. However, if the tube erosion happens, you have to take it surgically, and you have to dissect the eroded conjunctiva, use patch graft, conjunctival advancement, or conjunctival autograft. Pedicle graft has to be used if the conjunctiva has become avascular owing to previous multiple surgeries, and also use of fibrin glue. I will show this video of a young patient who came to us with the plate exposure was referred. He was one-eyed. He underwent both eyes trap before, and in this eye he underwent tube and also the primary repair by the surgeon. However, when he came to us, the tube again got exposed, and as you can see, there was a bleb superiorly, the trap bleb. So I decided to take up the patient surgically. I dissected the conjunctiva and realized that the plate was fixed quite anteriorly, and it came out very easily because the surgery was recent. And the tube was also cut very small inadvertently. So a new deep pocket was made at the same site, and the plate was fixed in the deep forniceal pocket 10 millimeter away from the limbus. So the routine surgery was performed here as we do the routine tube implant. And here conjunctival relaxing incision were given because of the multiple surgeries, the conjunctiva was falling short, and then the scleral patch graft was used to cover the tube. And fibrin glue is very, very useful in such cases wherein you have to put conjunctiva over the graft and bring it forward. So fibrin glue helps a lot. However, with the fibrin glue, you have to put sutures also at the limbus. And I also use amniotic membrane in such cases, complicated cases where conjunctiva is not so healthy and recurrent erosions happen. So this amniotic membrane is put in place again with the fibrin glue and sutures at the end. This helps in reepithelialization and healing of conjunctiva. So this patient has done really well, and in 2 years he's still doing well. The last video, I think this delayed hypotony again is very common in patients, especially who are uveitic and who have undergone multiple previous surgeries, especially cyclodestructive procedures, because it causes ciliary body hypofunction. So this particular patient was uveitic patient and chronic uveitis with choroidals. So I decided to stent the tube, and you can use proline sutures. This was an old case 3 years back. Now, so proline 40 suture was used in this particular patient. You can use 30 proline as well here to stent the tube, and then it is cut flush with the tube. So that way you can block 60 to 70% of the tube and manage hypotony. So since these cases are quite complex and refractory, it is important to anticipate problems and try to prevent complications. Meticulous pre and post-operative examination is crucial. Choose conjunctiva where it is healthy and not friable to prevent tube exposure. Frequent follow-ups is essential, especially if you're using non-valved implant at the time of ligature release to recognize signs of hypotony. So meticulous surgical technique, follow-up, and early recognition of complications are key to improve success of these complicated cases. Thank you very much.
Thank you, Dr. Suneeta. Those were indeed very useful tips for managing tube